Good evening. Thank you so much for joining us this evening on DeBakey CV Live. This is the Aortic Talks, and tonight we're going to be discussing advanced aortic imaging, specifically PET and PET-CT, and its utility in aortic disease. Tonight's program, as always, is going to be interactive, and we'd ask if you have questions, please go ahead and text the word DeBakey, D-E-B-A-K-E-Y, to the telephone number 37607. The other way to get to us is online with questions to pollev.com/DeBakey, where you can ask questions, and we'd be happy to entertain any questions that you have this evening. Again, we are also on social media, and we'd ask that you follow us here on at DeBakey CV EDU is our handle at all of the aforementioned social media sites. And great, thank you so much for joining us this evening. And tonight we have the honor and privilege to have Dr. Muaz Al-Mallah, who is the distinguished Arnold Chair in the Department of Cardiology, Professor of Cardiology here at Houston Methodist DeBakey Heart and Vascular Institute. Dr. Mallah, thank you so much for joining us this evening. Dr. Mallah is an expert in the world of PET, and specifically PET-CT, and thank you so much for joining us.
Thanks for having me.
Yeah, of course. So tonight we'd like to begin and discuss its utility and role in aortic disease. So,
Sure.
I think you've got some kind of general background information that we'll start off with first.
Sure. So, PET-CT has been a technology that has been around for some time. It hasn't been used much in terms of aortic disease, but there is some data and there is a lot of interest that's emerging in this field here. So, people know gamma cameras and SPECT-CTs more often because this is the kind of nuclear technology that we use day in, day out for our myocardial perfusion imaging and other technologies. But now we have more and more sites doing cardiac PET and cardiovascular PET imaging across the country. And this is the digital PET-CT system that we are lucky to have here in our institution. And we are the first in town to have this kind of technology, which allows open new horizons to allow us to image cardiac and vascular applications for cardiac PET. So just for those who don't perform cardiac PET or cardiovascular PET, we'll show you what is on our menu. So we do perfusion imaging, and this is a huge topic in itself, so we will not cover it today, but it in short allows us to image whether there is a problem in the coronary arteries and whether it is macrovascular or microvascular. We can also image viability imaging prior to needed surgeries, but we also image inflammation in the myocardium like sarcoidosis or other inflammatory cardiomyopathies, as well as now a new imaging thing is the imaging of infections, and we will cover some of it today when we talk about vascular diseases, and also imaging of vascular graft infections that is now being seen here.
Let me ask you, in your clinical practice, what percentage of studies done today at Methodist are done for myocardial perfusion imaging versus these other types of clinical indications?
So, for myocardial perfusion imaging, still the basic kind of application that we use PET-CT for. And it varies from different practice to another because we have a busy practice, and we have also multiple surgeons who do high-risk procedures, and they want to see different applications. So we are seeing more of the other applications in terms of viability imaging, inflammation, and others. So at least in our practice, we will say 60-40 in terms of myocardial perfusion imaging versus other imaging modalities for sarcoid, for viabilities, for high-risk surgeries, and others.
Okay.
So, but this is not reflective probably of other practices where the bread and butter is like evaluation of chest pain, and myocardial perfusion imaging would be still the main one.
Okay, thanks.
So if we move down, like what are we using? If we're gonna look at PET-CT specifically now in aortic diseases, so we're not gonna focus on the heart, we're gonna get out of the heart for some time and focus on the aortic structures and vasculature, arterial structures. What are the what can we potentially image for it? Some of these are clinical applications that we can use day in, day out for our clinical practice. Some of them may be more still at the level of investigative and still about for research. The first one is imaging atherosclerosis, and this is where probably it all starts. We use tracers that will go and image inflammation. You know now the theory of atherosclerosis being more of there is some inflammatory process happening there. And what we can do is that we can send some targets that can be picked up by these inflammatory cells, and now they light up. So we can detect some minor inflammation, some high-grade inflammation. That's the upside. The downside is that we are not specific in terms of the most commonly used tracers are fluorodeoxyglucose or FDG, which is this can be picked up in many other conditions, inflammation, tumors, and others. So we are not very specific by the signal we get. We are pretty sensitive where we can detect it.
Can you give us a clinical scenario when you would want to image atherosclerosis using PET?
So for atherosclerosis, most of these are still at the level of investigation. But like for example, for carotid disease, this is a common scenario where people like, if you have a patient who's coming with stroke and you have two lesions bilateral and you're doubting which one would be the potentially culprit, if clinically both of them can be applicable, or if you want to target, you want to give preference to one versus the other. Obviously, clinically you look at which one is more symptomatic and which one is more stenotically severe. But also if you want to look at the plaque instability, this is where one area that it will tell you that there is a lot of activity in this plaque. It is at a higher risk of rupture, and you may want to target one versus the other first. But most of it is really to look at, has been looking at patients with stroke who go for carotid endarterectomy, they get a PET-CT, and now we can potentially correlate our inflammation with the activity that we see in the plaque. However, it's like most of our clinical decision does not include PET in there, and still more in the in the research arena, looking at impact of therapies on these plaques and how active these plaques are and vulnerability of the plaque itself.
Is anybody looking at this in patients that have an asymptomatic carotid stenosis, say maybe 70%, that you're on the fence about whether you would do something or watch it, and then maybe use this type of imaging to look for the unstable plaque, and maybe you're more prone to intervene on those patients?
So that would be a good way to look at it. It has, at least I'm not aware of things that have looked at it. Most of it has been mostly validating it among patients going for carotid endarterectomy.
Gotcha.
So to try to ensure that what we pick there is more is the disease, the active plaque in there.
Gotcha. Okay, thanks.
So I'll show you here like some examples. For example, this is for example a patient with atherosclerosis. You can see the plaque in there, and it is lighting up, and I use different color scales because different readers like to look at it either in a black and white. This is in the descending aorta, and you can clearly see that the other walls are not uptaking any FDG, and at this segment itself I see the uptake here next to the arrow. So you can clearly see that this is a patient who has a plaque in there that's pretty actively inflamed, and it may call for trouble in this patient. Most of the time these scans would be done for other causes, like for example a patient who's got history of cancer and he's being imaged for lung cancer or others, and they find this plaque. So it kind of become, for atherosclerosis, it's more of an incidental finding that help us guide our therapies potentially.
Okay.
This is, for example, another patient from our practice recently who had an FDG study for another reason. But when looking at the aorta, we can almost track it without contrast. You can see it even on cross-section and ascending and descending aorta. This patient had a lot of plaque in there, and you can see the amount of inflammation. You can see all this black stuff across the wall of the aorta is not normal. This is all FDG uptake in this patient. And you can see there is significantly significant inflammation in the aorta here. So this is another patient where would potentially tell you that there is an inflammation there. Now, the hallmark where PET-CT, I would say, would be the most useful test clinically, and it has been used clinically among patients with inflammatory aortitis. So we're talking about giant cell arteritis, Takayasu arteritis. This is where it's going to be very helpful to pick up these patients, and it's very helpful in these patients not only to make the diagnosis, but also to follow them up and identify, titrate their therapies. I'll show you some examples with that.
Great.
So, for example, this is a patient who, from the literature, who has chronic periaortitis, and you can see significant FDG uptake in there. If we go in here, this is a patient with giant cell arteritis, and you can see the amount of uptake in the aorta. So this patient is clearly having significant inflammation there. And with the known history of giant cell arteritis, this patient is at a higher risk of aortic events in this.
Sure.
And so here's one case from the literature, which is very nice, but you can follow these patients. So here's a patient who was diagnosed in November 2011, and he was started on steroid, for example. Following them up on 5/12, the dose was very small at 4 milligram. Now, when they followed them the patient up in 6 months, now there is even increase in the uptake, and now you can see that there is even the inflammation is getting worse. So he was put on the higher dose now, and later on the November 2012, 6 months later, now it's all gone. The inflammation has improved significantly. So instead of tapering, technically they went ahead and completely stopped the dose, which come up with a flare another time again in few months, which after going back to the higher dose, now the flare has significantly improved. So you can see certain examples like this, which we follow the same scheme, for example, in the heart for other inflammatory cardiomyopathies. So now we're taking it just outside the heart, same scheme, to the aorta. It will help you guide your therapies. Is it safe to stop it? Is it safe to taper it? Are these symptoms coming up from a flare or not? Especially if the patient is experiencing high doses from the steroid therapy and others.
Right.
So yeah, I mean, this is where I would say PET-CT is probably the closest to be for the aorta for the clinical application. And this is very helpful, as we said, not only for the diagnosis, but also, I mean, CT also have some typical features in there, but sometimes you need to do contrast and you're going to repeat it and image the patient. So, and CT, while there are some chronic changes sometimes from the anatomy itself, it doesn't give you the inflammatory burden. So yes, you can see edema and others with wall thickening, but wall thickening could be from different reasons. So here, with adding PET to the mix, it will be complementary to CTA, which is more commonly clinically used, and it will help guide you that this is inflammation, or it could be just chronic thickening from recurrent inflammations from these patients.
In one of those patients, how often would you repeat their PET imaging to adjust therapy?
I would say if there is worsening of clinical symptoms, obviously that would be one way to look at it. The other thing is, after major changes, like once you demonstrated that you have suppressed inflammation, with major changes in the dose, like stopping it, you want to confirm that it doesn't come back again.
Gotcha.
Now, we have like potentially other areas, so this is not only in the ascending aorta, but it can also be seen in the descending aorta, and this is another report which clearly shows also that the correlation with the different inflammatory cells that they could see from biopsy in these patients, and this is aortitis in the descending aorta for this patient. So I would think that this is, like, if you ask me which one would be the closest to clinical application, this is where the area that will be closest, and mostly in Takayasu arteritis, giant cell arteritis, this type of arteritis where you have to suppress them and use high dose steroids and sometimes other anti-inflammatory therapies or immunosuppressive therapies, where it is very much needed to be able to control these symptoms. Otherwise, major complications could happen for these patients.
Okay. And allows you to adjust the dosages based upon
Exactly.
imaging. Great.
Now, moving on to other potential implications, again, at this time now, going into intramural hematomas and dissections, still CT and contrast-enhanced CT would be still the way to go for these patients.
Sure.
Rapid, quickly, we're not going to make diagnosis here, but from a understanding the mechanism of how these things develop,
Right.
or understanding how we're going to go ahead and target therapies for these patients, then it will be very helpful to look at some of like what would differentiate an acute dissection from chronic dissection or an intramural hematoma there. So, for example, this is a study looking at an intramural hematoma close to the arch, and you can see significant FDG uptake in there, which tells you that this is not a very benign process. Whether this was going to expand and it will have long-term sequelae, it still have to be determined what's the added value of PET in these specific areas. Another area is aortic dissection, and sometimes, as you know, we struggle to know which is this acute.
Sure.
Patient comes into your practice and they have a descending, they had some back pain, abdominal pain. You don't know if this is acute, chronic,
Subacute.
subacute. You want to know how stable it is, or sometimes in these quote-unquote semi-stable type B dissections that you want to know, would they progress? Do I need to monitor them more frequently? Do I need to monitor them less frequently? I think if there is inflammation in there, then it tells you that this is not a quiescent kind of pathology, and
Right.
you need to go and look for this. So looking at the aortic dissections, for example, this is a patient who had some dissection. The flap may not be very well seen, but it's there, and you can see there is significant FDG uptake in that same area. And this is a 37-year-old with acute type B dissection. When we look, for example, in another patient, 65-year-old, now this is chronic after the acute phase, and you see no uptake in there. So it's kind of like the inflammation is less. So in the acute phase, there is still the inflammatory markers there. And in this study, for example, when they looked at the unit, so we have an objective way to look at the inflammation in these patients called SUV, standard uptake value. So it's similar to Hounsfield unit that we use on CTs and others. So to kind of more be objective and quantify how much FDG uptake in there. And there are two ways to look at it. One of it is just the absolute number. And you can see here the SUV max in acute is actually higher than those who are chronic stable. And among the two patients in this study who had the progressive type, they had the highest FDG uptake. Now, obviously, small study, but hopefully at one time we'll be able to determine which patients progress, which patients may not progress in there.
I could definitely see that this would be useful in patients that have chronic renal insufficiency but not yet on dialysis. You really want to avoid iodinated contrast imaging in these patients, and this gives you not only the CT portion of things to be able to measure diameters, but it can also give you some of the inflammation, and
you
those patients may be higher risk.
And you get the non-contrast part, and you get so you get a rough measure of from
Diameters,
the non-contrast
yeah.
CT, but also you can see the activity in there. And if there is not much activity, then you may have a point in potentially looking at delaying any major intervention.
Sure.
If there is no other clinical criteria, if the patient doesn't meet any other clinical
Right.
criteria for intervention.
Great.
Okay, and this I noted in the literature, and this was actually a nice case report from the European Heart Journal, I think. And what they noted actually is this is an FDG in a patient who eventually had the dissection in 2013. But this patient had actually 5 PET CTs before for lung cancer. So they went back, pulled all these CTs, and then they started to look at the PET CTs in there and try to see if there is any sign that this patient might develop a dissection later on. So you can see here there is no uptake in the earlier scans. You might argue that there might be minor increase, but then at the time of dissection it went up significantly as a signal. So there was nothing before that. And you can see here when they plot it, you can see that this is actually the uptake was like very minimally increased. So it's not, I wouldn't say I would make a major claim that it is increasing here, but obviously the diameter went up from 42 to almost 47 before dissection, and now at the time of dissection it was 57. So the diameter and CT parameters are still gonna be your best way to follow these patients rather than, but if you note accidentally or intentionally that there is increased FDG uptake, then it is a sign to follow that this is not a completely benign process.
Gotcha. Early warning sign.
So it could be an early warning sign that you might get from different imaging that could be done for other reasons in these patients. Now, if we move on to abdominal aortic aneurysms, so this is another scenario where you can see if I see an aneurysm, can I predict which one will expand rapidly, which one will expand less? And this has been kind of the subject of multiple investigations using fluorodeoxyglucose. And the data with the fluorodeoxyglucose have been kind of like, some studies showed it's helpful to predict, some studies showed that it may not be the best predictor. So the increased uptake did not correlate with expansion and others in other studies. So recently the group from Scotland, from Edinburgh, have suggested maybe we should use a new tracer called sodium fluoride. So 18 sodium fluoride. And this one actually is a tracer that's almost always used for prostate cancer. So our colleagues across the street and other oncologic practices, they use it to look at prostate cancer and whether it's invading the bone. So it does detect microcalcifications in there. And you know, atherosclerosis and inflammation, it does involve some of these microcalcifications. So can we potentially use it to detect these areas and predict, so at least thinking that if there is increase in uptake in the abdominal aorta, then there is increased risk of rupture. And this paper was published in JACC a couple years ago, and they look at these micronodules of calcification and try to see if there is correlate with uptake. Here's one example where you see that the patient actually has an aneurysm and there is clear uptake in there. Now remember, this is sodium fluoride that is going for calcification. That's why you see all the spine picking up. Right. So the bone is going to pick up, but also the aneurysm here picked up significantly, as you see. So this patient clearly has uptake in this one, and whether is this a bad sign or not, and this is where you can see it also on a cross section. So you can see the uptake in the aorta, and you can see it here on the uptake and the cross section in the abdominal aortic aneurysm. When they looked at nearly 72 patients, it did in some patients who went for surgery, the uptake correlate with inflammatory cell among those patients who went for aneurysm repair and resection at that time. But what is more important is the outcomes data that they present, which is looking at the risk of expansion. So those patients, as the uptake of this sodium fluoride increase, the risk of expansion increases significantly. And similarly, the risk of abdominal aortic aneurysm rupture increases significantly. And similarly, the need for abdominal aortic repair, abdominal aortic aneurysm repair, also increased significantly. So at least this is showing that It appears to be a good marker. Obviously, we have only one study, and we're not going to change guidelines based on one study. We need more confirmation from different centers and look at the variability of this. But at least we have a good sign that we may be able to determine, like in the vascular lab, you see now a patient, and this patient has an aneurysm of 4.5. I would think that if this kind of algorithm turns out to be true, maybe in a few years' time, we will say, let's get a PET CT. If the PET CT shows uptake, then this patient need to be not managed and surveyed every year or 2 years like the guidelines say. Maybe we should survey them earlier, because these patients are at a higher risk of expansion, rupture, and need for repair.
Gotcha. Okay.
So at least promising data with using this tracer, which is very well available and ubiquitous. I mean, it is easily handled, and it's...
How difficult is it to make these tracers? Don't they have to use a cyclotron? And
yeah, but I mean, nowadays this one has a half-life of 2 hours, so technically you can potentially, if there is a cyclotron in the city you live in, it doesn't need to be like far away.
Gotcha.
Then it doesn't need to be just next to the machine, because this F18 based agents have a half-life of 2 hours, so technically you are able to get the dose you need. And now there are companies who will tell them, I need 10 millicuries of sodium fluoride at 11 a.m. and they will bring it to your hospital on time.
Okay.
And obviously here in the medical center we have no shortage of cyclotrons, so we are lucky. But even if someone doesn't have it, as long as you have a cyclotron in town, most of these centers are able to get the tracers they need. And this is how PET oncology is operating nowadays.
Okay. Well, before we go on, we've got our first question here. So the question is, how can PET CT guide cardiovascular surgeons on the surgical management of ascending aortic pseudoaneurysm?
So this is a good question, and I would say that at this time, obviously, we don't have solid evidences for this, so this is still within the area of research. But I would say for pseudoaneurysms or for any of these, if you detect inflammation in this, and whether in the aneurysm or in the pseudoaneurysm may be a little bit different, because we're talking about like potential rupture and like more of a clot in there. So I'm not sure how much we have data for pseudoaneurysm, but if it is like an aneurysm itself, I would say whatever applies to the abdominal aortic aneurysm, the data that we showed probably will apply to any other, not necessarily just the abdomen. It could apply to the ascending, descending, and maybe other vasculature too. But in pseudoaneurysm, you're still relying a lot on CT angiography to determine the size, because unless you're implying that there's a rupture and a hematoma in there. Now, obviously, if it's a chronic pseudoaneurysm that has been there for some time from a like motor vehicle accident and others, still the presence of inflammation would be a bad marker for this.
So I think that may be the crux of the question they're asking is, if you have somebody that has an IMH of the ascending aorta, especially if it's subacute, some of those patients you may watch, see if it regresses, expectant close monitoring, re-imaging again with CTA, but maybe this will be a better imaging study to help determine that.
It will help you. In fact, I would think of it more of a synergistic tool to CT, because CT, we deal mostly with anatomical features. So we're looking at size, we're looking at wall thickness, but we don't have the metabolic activity in there. So we're not imaging them at the molecular level. So adding the molecular level, it will augment your CT information, and it will help you better stratify. Because we follow these patients with aneurysms for years. Some of them never progress, some of them progress mildly, some of them but never make it to surgery, and some of them progress very rapidly, and you'll be surprised how quickly they make it to the OR for these patients. So if we can detect these patients at the time of diagnosis, or detect who will rapidly progress versus who will progress more slower, and we have time to deal with that. So it will have probably implications for therapeutics meanwhile, who would aggressively treat with very aggressive blood pressure control and other medications, but also at the same time who will be at higher risk of requiring more surveillance, taking their symptoms more seriously if they develop any worsening or deterioration that can be attributed to the worsening of their aneurysm in these patients.
Gotcha. So we have a second question. The question is, does PET-CT imaging have a role in thoracic aortopathy syndromes such as Marfan's, bicuspid aortopathy with a bicuspid valve, etc.?
So that's a good question, and this is one study we are looking at. I know that there is one center, also the Edinburgh group, looked at it in abstract forms. And again, what we showed just right now for the abdominal aortic aneurysms and these uptakes that you see in these patients are not potentially specific to the abdominal aortic aneurysm. They can be potentially seen in others. Now, Marfan in specific, I don't know, but I would say, I mean, once you get to the genetics, there might be other mechanisms. But for example, but maybe for other conditions like the ascending aorta and others, it will be more to think around that line, but again, we don't have that data yet. And remember, these are just like emerging fields within newer technology and widely available tracers and machines. Now we're starting to understand the molecular mechanisms of these aortopathies, being inflammatory to atherosclerotic to other
genetic,
types.
etc. Has there been imaging done in Marfan's?
I'm not aware of much in there. I've seen an abstract on bicuspid on very few patients, and it looks promising as this one too.
Okay, great.
Okay, so yeah, these are like mostly in aortopathies, and we've looked at some of these images, looking at the risk for rupture and aneurysms. Finally, this is where I would think this is probably the most validated clinically, which is looking at infection. I mean, because in infection, now you have a collection of inflammatory cells. So there is a mega inflammatory response in there, so it's not minor. And PET has been used to look for potentially infections and patients with fever of unknown origin for a long time.
Right.
And we started also to look at it in the heart itself. So one of the examples is looking at prosthetic valves, devices within the heart. So if a patient has a prosthetic valve, they're coming in with fever, and somebody saw something flickering on the echo, which could be pannus, could be thrombus, could be an infection. Now you need something, a tiebreaker to differentiate. Is this an infection that's going to go your route to the OR for a high-risk redo versus just like treat with antibiotics for a pneumonia that has nothing to do with the infection?
Right.
And some infections may be devastating, as you see in here, where like the entire like graft and root is affected, and some of it may be just self-limiting. So like here you have an abscess and root infection, so this tells you that you're sitting on a time bomb and you need to go to surgery.
Right.
While on the others, it may not be as bad as you see here. For example, here it's like more of an abscess or a smaller infection, but not as bad as what you see here. Now, the same thing could apply also to the ascending aorta and TAVRs. For example, this is a patient who had a TAVR graft infection. And you can see all this lighting up. So on this TAVR prosthesis or prosthetic valve, now you can see the infection. And this is again not all what we can say is there is a big time infection there, but we can also quantify it, and again applies the same thing. Follow it after therapy to see if it resolves or not. Now, obviously, it becomes more complicated in terms of detection if the patient has taken some antibiotics. So now the inflammatory response kind of weaned off a little bit.
Cultures may be negative.
Cultures may be negative. So yeah, I mean, you may potentially end up with some other false negatives.
Is the tracer used in the infection studies? Is that tagged white cell scan, indium 111? What is the tracer that's typically used for that?
We're still using also FDG here, fluorodeoxyglucose, because it is still very helpful. Now there are some other tracers, other groups have tried to look at tracers on, instead of imaging the white blood cell, now we were going to image the bacteria, for example.
Oh, wow.
Now, So, for example, you take target antigen that's from the E. coli bacteria or Staph aureus bacteria, the gram-positive bacteria. So, some of the common antigen, try to target them. The problem with them is like you have way more white blood cells than you have bacteria there. So
right.
the signal you get is much less. So it's not going to light up as much as you see here.
Gotcha.
And you may not be able, you may have false negative because especially at the later phase. So, or with some mild treatment with antibiotic, now you don't have enough bacteria to image them. So, and obviously, if you have too many bacteria, probably you don't need imaging.
Imaging anyway, sure.
The patient would be much sicker and septic and in other difficult conditions.
Gotcha.
But the same concept which has been applied to the heart, applied to hardware within the heart, now is being applied to other parts of the body, including the aorta. So this is, for example, a patient, also from the literature, with an abdominal aortic aneurysm, which eventually got infected there. So now one common problem, I would say not problem, but more of a challenge, is how do we differentiate between inflammation versus infection? And
right.
Usually infection has way more white blood cells. Inflammation from atherosclerosis and others will have less. But if you talk about, like, can I differentiate between giant cell Takayasu type of inflammation where it's very intense versus a mild infection, this is where we have some overlap
or
issues.
Inflammatory abdominal aortic aneurysm versus infected, primarily infected.
Yeah, so inflammatory abdominal aortic aneurysm, unless it's like a very bad inflammation, usually infection will have more uptake.
Okay.
So, but like, for example, after a graft surgery, you will have some healing process going on, and there will be some inflammation happening around that part of the healing process after the surgery. So in that time, if you do an FDG, you will probably see some uptake around the graft, and this is known just after, in the early phase after surgery.
Sure.
But let's say, God forbid, that got infected, the intense inflammation, usually what we are seeing is that it becomes way more than what you see just from the simple inflammation of the recovery period after the surgery.
Yeah, definitely could see its utility in patients that have an inflammatory abdominal aortic aneurysm. You see that thick rind all the way around the aorta. Many times you can treat that with an abdominal stent graft, which would be, the exact opposite of what you'd want to do if you knew that the aorta was infected. Leaving hardware in the middle of an infection, obviously you would never do that.
Now again, as I said, we're dealing here with probabilities, so it's like if it is intense uptake, then most likely it's an infection, but if it is less of an uptake, then it's more likely to be more on the inflammatory side. But you can still see like severe inflammation and like aortitis type situation where it becomes so you have to look at it more into the overall clinical picture. I mean, somebody having positive blood culture and has this type of uptake, then you would assume that this is more of a infection rather than inflammation.
Great.
And this is the same patient, like another patient who did not have like an uptake but also have an inflammation, as you see in the aorta. So here the uptake, like this one is more intense, this is less intense in this patient. So there is some uptake, but it's less intense, so kind of differentiation between the two.
Gotcha.
Now this is like one of our cases here where actually the patient had the aorta bifam. We were asked, because the patient may have an infection, we were asked to look at it. So we're starting now at the level of the knee and we're moving up. And we're gonna focus on this graft here, and you can see the graft. So I'm gonna just move the movie back. And you can see the graft in the middle, and you can see all this intense FDG uptake in there around it. Now, if you contrast, the other side also has a graft, but there is no uptake, or there's like minimal inflammatory uptake in there. So you can clearly see the differentiation between this one. So if I take it back here, so you can see the intense uptake here versus just minimal uptake here.
Gotcha.
We're moving again, same thing, this would be more of an inflammatory kind of response. This one is more of a kind of very severe
infected femoral popliteal bypass graft.
Exactly.
Yeah.
And now we're moving up. It's going all the way to the groin. We're moving up, and you can see it here. And we did the reconstruction, and you can see all this intense inflammation that you potentially infection that you don't see here. And this patient actually has very bad infection that you can see all through here. So now you have the contralateral side to kind of guide you, tell you this would be an acceptable level, but this one is clearly much different between the two.
Gotcha. Graft
So,
needs to come out.
I think, yeah, I mean, this patient, it has to come out. I mean, when you have this much infection, then this is going to be very different scenario between the two if you don't treat it versus like surgery.
And was this done as more of a just out of interest to see exactly, or was there some clinical question in this patient?
So there was a concern in this patient because this patient was even an outpatient and he was put on antibiotics, and he's thought that he's feeling better and there is a little bit less erythema, although there is clearly an infection. So there was, with the infection, how bad is it? Can we wait on it, or is it like has to be done? It's like, because this patient even had some antibiotics first.
Gotcha.
By the time we did it, it's like, nope, there is a long way to go, and I don't think antibiotics are going to be able to achieve that, and this is why we recommend, I mean, discussing it with the referring physician, recommending surgery for this patient.
Okay.
So this would be another potential application, and this one is, I would say, ready for prime time, ready for clinical use, and we are looking at it in one research project in specific, looking, for example, for dialysis grafts with Dr. Rahimi from your group, and because these potentially are more prone to infection with the every dialysis session, and sometimes you don't know how long to cut in these patients, how bad is the infection. So this is something else we're looking at in these potentially in these patients.
Great. I think we've got another question here. Can we use PET-CT before angiography in cases of myocardial infarction?
So this is kind of a little bit outside the aorta, but going back to the heart, our comfort zone. So yes, I mean, PET-CT for before angiography in myocardial infarction, it depends what you're looking for. If you want to do perfusion, I would say, unless you're preferring not to do catheterization, then this is where it's like you don't do a stress test on a patient with myocardial infarction. But if you're looking at viability, for example, this is where it makes sense. So if you're looking for viability and whether there is need for revascularization, or is the area that is akinetic viable still to warrant revascularization in this patient, then I would say it would be helpful to do that. Just to keep in mind, I mean, right now this whole debate about the utility of viability versus limited use of viability in these patients, I would say it still adds up in some clinical scenarios which were not well tested in the STITCH trial. I don't want to make this a STITCH discussion, but clearly there are still clinical scenarios where it does add much information there.
Well, I've got a loaded question for you here. Tell me, when would you choose cardiac MR versus PET-CT in terms of viability?
So for viability, I mean, most of the time, let's put it this way, if we want to summarize the strengths and limitation, strength, I would say in the meta-analysis and others, sensitivity-wise, nuclear techniques in general and PET in specific was found to be the most sensitive. So if you're looking for sensitivity, PET would be the way to go. MRI has the advantage is that the only modality where you see the scar itself. So technically, if you see the scar and you're not able to, then it's unlikely to benefit. Now, there are a lot of scenarios where either one would be a good tool to look at. But obviously in patients with renal failure, in patients with devices, even if your side do device MRIs, the image quality may not be the best in these patients.
Okay.
And there will be artifacts from the device depending where the box is, where the lead is. So this kind of scenario, there are other situations where renal failure, you cannot give contrast to be able to get that. So obviously claustrophobic patients, although these can be still like treated and prepared for the scan, but still there are still these patients, I would think they are more into the MRI, into the PET area. For example, in PET, we do have some challenges with patients with diabetes who are on high insulin requirement and insulin resistance. So if I know the patient, at least personally, if I know the patient uses very high basal insulin, we may run the risk of being unable to get good images, and I would recommend that we can start with MRI and we can complement it.
Gotcha.
But I think most of the time these two techniques are like complementary and comparable in terms of accuracy. But I would think that there are areas, as I said, the renal failure and the devices are probably better served by PET, because these patients will obviously not get gadolinium for viability if they are like low GFR, or if the device's image quality may be a little bit lower than the usual image quality we get with the typical nice cardiac MRI as we get in our lab here.
Are there times when PET CT would also have limitations, or patients you would not want to use that in? You mentioned the diabetic patient that's on high dose insulin, you may not get uptake.
Yeah, it depends on, I mean, for stress testing, I would think that, I mean, if you want physiology, both technique, I mean, PET is probably the most sensitive, and recently in a in a single center study, but multiple modalities were compared head to head. PET clearly pairs out as the most sensitive technique. So for myocardial perfusion imaging, there is no doubt that PET would be the way to go for these patients.
Okay.
For sarcoid, we often, like other inflammatory cardiomyopathies, we often think that you probably need both more commonly to be able to look for these, because each one of them is detecting something. One of them is looking at scar, one of them is looking at disease activity. So you're looking at the problem from different angles and be able to achieve different accuracies. So most algorithms for sarcoid and inflammatory cardiomyopathies, we will require both techniques more often.
Okay. Are there any patients that couldn't get a PET CT?
I mean, we had like one or two claustrophobic, although our bore is probably among the widest bore. But I can't think of someone who, I mean, there is radiation exposure, but the radiation exposure with PET CT is not even comparable. It's way less than other techniques. So for SPECT, we are using almost like, we are between 10 to 20% of what we get for SPECT for myocardial perfusion imaging. So we are still, you're better served between PET and SPECT in terms of radiation. So, I mean, other than this, I don't think that there is limitation on the technique. But we have mainly, as we showed on the very first slide, I mean, these are the main applications that we are using PET CT for, which is for clinical myocardial perfusion imaging is the main one. Viability is being used frequently. Sarcoid, because we have a high referral base for inflammatory cardiomyopathies. Prior to transplant, many patients got referred for advanced heart failure and want to know what's the etiology of their cardiomyopathy. And part of it that they get an MRI, and the MRI has like showed scarring, and want to know, is it actively inflamed, not actively inflamed. I think PET has a very complementary role there. And infection, whether it's in the hardware, in the prosthetic valves, LVADs, pacemakers, pockets, all of these are very helpful. And we talked about aorta and potential other aortic implications.
How useful is it in LVAD patients with the device and then the drive line coming out?
So yeah, I mean, I didn't put here, but there have been multiple studies that have shown that it's very accurate and does predict the site of infection in these patients. So whether it's in the hardware itself or in the drive line, and obviously if it is in the central unit, central infection, it's kind of the worst outcome for these patients. Okay.
We've got another question. PET CT and cardiac masses. Any information for surgeons?
Yeah, I mean, there are it will help you to detect, especially in metastasis, of how far it is involved, and because most of cardiac tumors are metastatic, there are still, so if you decide to do, like for patients who have other types of cardiac masses, whether you want to look for benign versus malignant, obviously it has to be prepared in a way that you suppress the normal myocardial uptake. So if it is a cancer, you want to make sure that the cancer will light up, not the normal myocardium, because also, as you see here in the viability image, in viability we will get normal uptake from the myocardium. So what we do is that we want to suppress the normal myocardium and just have the mass kind of light up if it is malignant in there. Although it's one of the areas where it is less kind of studied in there, but because most of the time, by the time the metastasis reaches the heart, the patient already has a tissue diagnosis. But in terms of masses, initially, yes, it will be very helpful.
We have a big cardiac sarcoma practice here at the hospital. Is there a role for PET CT in those patients, benign versus malignant?
Benign versus malignant is very helpful, PET in general, even not only in cardiac and other malignancies or tumors in general. Now, in specific sarcoma, whether malignant versus cardiac, I don't know in a specific study looking at it, but in general, to differentiate benign versus malignant, PET is the way to go for these patients, whether it's in the lung, in the brain, and many other organs. This is how PET for oncology has been, or oncologists use PET to kind of differentiate malignant from benign.
And then they've got another question here. Will PET CT take the place of indium-labeled white blood cell scans for infected grafts? Workup, in your opinion?
So I think, we don't have a lot of data comparing it. The study that I can tell you is looking at cardiac infections. And in these studies, when they compared them head to head, it actually, PET CT kind of finds as more accurate in these patients. So
and that's using FDG as the
That's using FDG. So again, for the white blood cells, for indium scan, I wouldn't say they are obsolete, but now if you want to detect infection, most practices kind of move toward PET as if you want a more sensitive test in there. Although there are scenarios where you may need potentially both of them to be able to have complementary information.
Okay, great. Last question for you here. So in the next 5 years, where do you see PET CT taking off, and what different modalities is it going to be used for?
So obviously for myocardium, this is going to be, it will continue to progress. I think we're going to start to see some more of the non-perfusion applications kind of become more clinically available. So sarcoid, for example, inflammatory cardiomyopathies, inflammation in the aorta and others, but also the infection kind of paradigm, whether it's cardiac infections, devices, LVADs, grafts, pacemaker, all this that we have not clinically done. I think we have now a good solid evidence base that will tell us that PET has a role to play in these patients and to guide management in these patients.
Great. Well, thank you so much for joining us this evening here on DeBakey CV Live Aortic Talks. Thank you, everybody at home.
Thank you.
Thanks.